Hello, everyone. Thank you for joining us for this month's webinar on our Housing Insecurity Learning Cohorts. This month, we'll be focusing on building community and C-suite buy-in. Just a few housekeeping items. For the duration of the call, you will be muted, but we will be taking questions at the end of the presentations. So if you do have questions, please type them into the question pane located usually on the right side of your screen at the GoToWebinar platform pane. So we're really happy that you are joining us today. We will have a recording of this webinar available on ForumB, the discussion platform software that we're using for our learning cohorts. But without further ado, I'm going to pass it over to Alex Lewin-Sortling to introduce our speakers.
Thanks, Monique. I'm thrilled that you could all be here today. I just wanted to quickly introduce 3 speakers that we have for today's Housing Insecurity Cohort session. Our first speaker is Julia Resnick. She is the Senior Program Manager for the Value Initiative at the American Hospital Association, where she supports the AHA's efforts to promote affordability and value in the healthcare system by improving quality and decreasing costs. Over her 7-year tenure at the AHA, Julia has been committed to advancing their mission on population health, including leading the Association for Community Health Improvement, AHA's professional membership group for community health leaders. We also have joining her Beth Kennefic. Beth is a program manager with the American Hospital Association Center for Health Innovation's Population Health Team. In this role, she manages research projects and develops resources that connect healthcare systems with communities to provide innovative practices that improve population health outcomes. And last but not least, we have Ron Kluwer. Ron is the Illinois Market President for Gorman & Company. Prior to joining Gorman & Company, he served as the COO of the Alliance for Strong Families and Communities, where he was responsible for operations of the National Association Operations Center in Milwaukee, Wisconsin, and the Public Policy Office in Washington, D.C. So I will turn it over to Julia. We'll have 2 presentations today, the first by Julia and Beth, and then the second by Ron. And as Monique mentioned, we'll open it up for Q&A via the chat function and the question function within the GoToWebinar following their presentations. So without further ado, Julia, take it away.
Great. Thank you so much, Alex and Monique, for that kind introduction. And a big thank you to the Root Cause Coalition for inviting Beth and me to share and learn with you all. We're both excited to be here for this kickoff of the Learning Cohorts webinars and to be part of the conversation about making the case for housing. So as Alex noted, Beth and I are both from the American Hospital Association, so our perspective will really be about how to make the case to hospital C-suite leaders and focusing there. So next slide. A quick overview of what we're going to be talking about over the next 20 minutes or so you know where we're going. We'll start off about making the value case to connect with hospital leaders, talk a little bit about the health and housing connection in a way that resonates with hospital leaders, share some case examples of how hospitals are addressing housing, and then Beth will share some lessons that we've learned so far from our involvement in the Accelerating Investments for Healthy Communities project, and then some strategic questions for getting started. So let's jump right in with the next slide. And we'll start with the big picture and thinking about what hospital leaders are thinking and hearing about. And right now, that conversation is all about coverage and affordability. And we can start with some good news. Since it's a Thursday morning, some good news. 9 out of 10 Americans now have health insurance. But we know that that's not the whole story. Next slide. As we see day in and day out, coverage does not equal access to care, and even access does not equal health. So next slide, we can see what that looks like in real life. Healthcare continues to be unaffordable for many Americans, even those with health insurance. Insurance premiums continue to grow, outpacing inflation, and the average deductible for employer-sponsored health plans tripled over the past decade. Next slide, please. And we're seeing how that plays out in that there's a bigger bite being taken for healthcare. Families are spending more on healthcare than ever before. Since 2007, middle-class family spending on healthcare has increased by 25%. This means that they have less money available to pay for other basic needs, like food, clothing, and of course, housing. And the next slide will show us what the result of all of that is. 1 in 4 Americans say that the cost of care is the biggest concern facing their families, and 1 in 3 couldn't access care because of cost. You may have seen a recent Gallup poll that came out the other day that showed that 13% of Americans, that's about 34 million people, know someone who died because they couldn't afford care. This is all to say that healthcare affordability is a serious problem in America, and hospitals realize that it is also their problem because it impacts their patients and their communities. Next slide. And that takes us, that's really the mindset that our hospital leaders are in right now. And they're asking the same question. How can we provide value to our patients and our communities? And how can we demonstrate our value? So back in 2017, the AHA had a dialogue with over 700 hospital leaders, and they shared that value can be a path forward to better healthcare affordability. And of course, what value means is different for all of us, and there's no standard definition of value across individuals or across the healthcare field. So based on our member feedback and the literature that is out there, we're taking a broad approach to thinking about affordability through a lens of value. And that looks like this equation that you're seeing on your screen. It's value is equal to improved outcomes, enhanced patient experience, and reduced cost. And the truth is, every hospital leader cares about value. And if we don't lead with value, we're not having the right conversation. You can go to the next slide. And value isn't a particularly new concept in the healthcare field. It's something that we know our hospitals and health systems are already starting to implement a variety of value-based strategies to improve each area of the value equation. At the Value Initiative at the AHA, we put those in 4 areas: redesigning the delivery system, improving quality and outcomes, managing risk and new payment models, and implementing operational solutions. And I know that the text on this slide is fairly small, but I think it points to something really important about value. And that is that every part of a hospital, every person in the hospital, every partnership that extends into the community connects that back to value. Everything that we do is part of improving value and working towards the value equation. So now we'll move on to a slide that I'm sure you've all seen a million times, but I think it's worth reiterating because it really seems to resonate with people who aren't as ingrained in this social determinant space, and we've seen it be kind of an aha moment for hospital leaders. So you all know only 20% of an individual's health is tied to clinical care, and the other 80% is the social determinants where people live, learn, work, and play. So if your hospital is committed to improving value for their patients and community, we know that providing excellent acute care is not enough. They need to holistically think about the social situation of their patients when they leave the hospital. And you'll note that I haven't directly talked about housing yet. And that's because the case for housing is part of that general value case for addressing the social determinants. And our hospital leaders need to be able to see the connection between what happens in the community and what happens in the hospital, and how it ties back to key metrics around outcomes, patient experience, and cost. So on the next slide, we're sharing some key questions that you need to be able to answer in your context. And unfortunately, I can't give you all of the answers because every hospital and community has different needs and has a different value case to be made for doing this work. So when it comes to making the case, I'm sure those of you who are on the phone are already fairly bought into this, but you need to be thinking through that value mindset with your leaders to lay the groundwork. Because though the social determinants work is essential, it's not hospitals' bread and butter. It's new, and you'll need a compelling case for doing it. And you'll need to have a firm grasp on your data and your metrics to show how and why your strategy is important and will impact value. And when I say data, I don't mean just the quantitative data. I'm also thinking about the qualitative data and what you're hearing from your community. Because housing and social determinants, they happen in your community needs to be engaged in identifying what those needs and what those strategies are that the hospital could adopt to influence the social determinants. And that case, of course, I feel like a broken record at this point, needs to link back to value, those outcomes, patient experience, and cost. But as you see in that second bullet point, there's also a moral and ethical case for doing this, which I think is like that heart work that drives a lot of what we do. So as you're making the case for hospital leadership, you need to be able to connect that business and value case with the moral and ethical case for addressing social determinants and housing specifically. I'll move on to the next slide, where we finally get to housing. So all of you on this phone, I think, know something that your hospital leaders might not intuitively know, and that's that housing is equal to health. And they'll need to be reminded of that, and they'll need to be shown that. And I think this table does a good gateway job of showing how there are these different forms of housing instability that are then associated with health risks for children and for adults. And in short, people can't be physically and mentally healthy if they don't have safe, stable place to sleep at night. And this is reflected in health outcomes and the cost of care. So if you can take these ideas and tie them to what you're actually seeing in your population and in your community, I think that should really make a strong case to hospital leaders. Next page. The other thing that you know that your hospital leaders might not is that not all housing is the same. So saying to a hospital like, let's tackle housing in all of our community, that can be pretty daunting for hospital leaders. But you really need to drill down into what that issue is in your community. Is the issue homelessness? Are you having issues with housing affordability and rents going up and people not being able to stay at their homes? Is it an issue of home safety with lead paint in the walls? Or is it a combination of all of these things? Again, I don't have the answers for you because that's one thing you have to drill into your data to figure out what is happening in your community. So linking it back to value, how can your specific housing strategy connect with other strategic priorities at your organization? You have to think about if you're addressing housing for your patient population or for the community in general. Both approaches do add value. It just depends on the needs of your community. And to extend that point, the effective strategies come in different shapes and sizes. There's no one right way or one wrong way to do housing. So I'll illustrate a few examples about how hospitals are taking varied approaches to their community's housing needs. Next slide. The first one we'll talk about is from our hometown, Chicago. This is University of Illinois Hospitals and Health Sciences System, who are working on homelessness in their patient population. And so their goal is to provide chronically homeless individuals with stable housing and supportive services through a housing first approach. Their ultimate goal is to help those individuals move into fully independent and permanent living situations. So when they kicked off this program, they identified chronically homeless individuals who were frequent ED visitors. And those individuals were moved directly into permanent housing and provided with a support system to help keep them healthy. In that pilot, they found, and they did a lot of good evaluation on this, and were found that the housing first approach was able to reduce healthcare costs for those individuals by more than 50%. And after 2 years, 90% of them continued to be in stable housing. And interestingly, the impacts of the housing first approach extended beyond healthcare, where there are similar savings for other social services that those individuals were accessing. So I think this illustrates really the power of focusing on a specific segment of your patient population to provide them with necessary housing support. And on the next slide is a very different approach to housing, more of a community development mindset that Nationwide Children's in Columbus, Ohio took, where they aimed to make the neighborhoods surrounding their hospital a better, safer place to live for their community and for their employees. So this started about 11 years ago, and at that time, nearly 1/3 of the houses near the hospital were either abandoned or derelict, and property values were depressed. So the hospital and a few other community stakeholders created the Healthy Neighborhoods, Healthy Families initiative to remove barriers to health and well-being in Columbus. And the initiative facilitates access to affordable housing, quality education, health and wellness programs, safe and accessible neighborhoods, and workforce development opportunities. But I'll note that they didn't start with all of those, and they really started focusing on housing and that physical environment. So over the years, the Healthy Neighborhoods, Healthy Families Realty Collaborative has built out 3 primary programs to support the neighborhood: home ownership, a grant program for home repairs, and affordable rental housing. And over the past decade, Healthy Neighborhoods, Healthy Families has added or maintained 315 affordable housing units. The number of partners in the coalition has grown, and they're starting to see the health outcomes from doing this change in the community. So for the youth living there, the graduation rate has improved and violent crime has decreased. They're also seeing property values starting to rise where the work has taken place. And interestingly, I think from the hospital perspective, they're seeing declines in the cost of care and emergency department care for children living in the neighborhood, and not just the ones in the new housing units. So it's really impacting the neighborhood as a whole. And this work is continuing and it's growing through their work with accelerating investments for healthy communities, which Beth will talk about in a little bit. But before that, I'll do one more example of hospitals that are working on housing, and again, a completely different way. And this is from Children's Mercy in Kansas City that is working on home safety. So they're focused on the health and safety of their patients' homes and schools to reduce chronic diseases caused by environmental triggers. The Healthy Home program visits and evaluates homes to identify environmental triggers for asthma and other chronic diseases. And when it's relevant, they provide families with a healthy home kit that can include vacuums, mattress encasements, furnace filters, and cleaning supplies. And for cases requiring more intensive interventions, such as eliminating mold or a pest infection, staff can refer families to local services or a community service agency. Since starting this program, they have completed over 750 home assessments and counting, and served over 2,500 families. And they're seeing the impact on their quality and outcomes measures, including reduced ED visits and hospital admissions. So I think that these three examples just show the spectrum of work that you can do within the housing space, whether you're thinking about homelessness, community development, or home safety. There's no one right way to go about housing. But however you do it, link it back to value and those key metrics that your hospital leaders really care about: outcomes, patient experience, and cost. And I think that will really help make the case for housing. So now I am going to turn it over to Beth to talk about our work with AIHC.
Thanks, Julia, for sharing those examples of how hospitals and health systems are starting to address their housing needs of patient populations, and in some cases, like nationwide, with their communities. Our next example comes from a newer initiative the Robert Wood Johnson Foundation is funding through the Center for Community Investment, or CCI, a group that you will all likely be hearing from on a future Root Cause Learning Cohort call. The Accelerating Investments for Healthy Communities, or AIHC initiative, is providing intensive training to a cohort of leading-edge hospitals and health systems on how to refine investment strategies around affordable housing in order to leverage existing resources with community partners. What makes this work innovative is that it's focusing on improving the community investment system as a whole by adding the participation of hospitals and health systems in an effort to support the development of affordable and safe housing, oftentimes regardless of whether community members are patients. What CCI will likely note in their cohort call is that the scale of transformation needed for such things like affordable housing can't be achieved through small community benefit and grants alone, but that with strategic choices, grants, and other assets that hospitals and health systems have can be used to potentially unlock additional capital and increase the scale of resources and consequently the impact of your social determinant health initiative. So for example, we heard from Julia about Nationwide Children's Hospital's Healthy Neighborhoods, Healthy Families program that includes what some of these more traditional programs around gutting and rehabbing homes. However, through partnerships with the Ohio Capital Finance Corporation and others, Healthy Homes has access to a $20 million loan fund to provide long-term funding for the acquisition, construction, and permanent financing of single and multifamily rental housing. In order to help create this loan fund as an incentive for the lenders to provide this type of financing, Nationwide Children's Hospital provided a limited loan guarantee to the fund, so an asset that they were able to do to unlock additional money in the community, rather than spending what might that money have been on the rehabbing homes itself. I will add that the framework for the community that CCI does, which is called the Capital Absorption Framework, is in the linked resources section, but I'll let them explain that more. During this project, the AHA and our colleagues with NORC at the University of Chicago are learning partners on this project, and we're attempting to provide insights related to the questions highlighted on this slide. what will it take for leading health institutions to devote more and different assets to investments in affordable housing and other upstream factors that improve community health? As the next slide shows, in that vein, we've been conducting interviews with members of the participating teams to learn more about the context that they're operating in, their motivations, and how they're engaging other stakeholders. To date, we've published one issue brief that talks about some of the emerging themes we've seen around motivation and making the case, what we're all here to talk about today. The two that sort of cropped up in these conversations included mission-driven commitments and then strategic alignment with care and payment models. In terms of mission, all the participating hospitals and health systems demonstrated an underlying commitment and drive to address the social determinants of health with an emphasis on housing. They expressed widespread acceptance that if their goal was to advance equity and improve health, it was their responsibility to support their communities. And they often referred to different characteristics, such as the ones here. I'm an anchor organization. I'm a nonprofit. I'm a safety net hospital. I'm faith-based, as you see in the quotes on the right. On the other hand, while mission is a driving factor for hospitals and health systems for investing in affordable housing, the old mantra, no margin, no mission, also applies for many. As we see new care delivery and payment models are starting to create strategic alignment to support affordable housing. So across participating hospitals, interviewees described the alignment of affordable housing with their strategy, particularly when they had a health plan or an accountable care organization. So to reiterate what Julia mentioned, it really depends on your own situation. Lastly, in the next slide, our partners at CCI are also tracking and documenting what they're hearing as these hospitals and health systems implement the work on the ground. And they've noted a few other motivations, such as reputation and competitiveness, strengthening community relations, meeting obligations to your community, and even leveraging assets strategically. Looking forward, our work will be diving into things such as building the will, community alignment, and identifying roles. But that being said, we're definitely interested in hearing from you all and what questions you have for these participating hospitals and systems as we continue to conduct interviews and analyses. Our emails are included at the end of this deck, and we invite anyone to send questions to ensure that our inquiries align with what the field is looking for. And with that, I will turn it back to Julia.
Thank you so much, Beth. I love seeing how what you're learning through AIHC and what we're thinking about in value all really tie together as we're trying to link, motivation for investing in housing and making the case, since they all go together. So these are some key questions and considerations for all of you to bring home with you and to think about. And by home, I really mean the online platform that our friends at the Root Cause Coalition have set up for us to discuss these issues. Because I think that we'll all share some commonalities here, but can really rely on each other to help tease out the main value cases for why housing is a high priority. What are we already doing to show that we can make impact, and what kind of metrics do we really want to change through our work on this, and then figuring out how it will align with leadership so that we can tell the story about what you want to achieve with your housing work. So on to the next slide. You note that so far we haven't really talked that much about the nuts and bolts of what hospitals are doing about housing, because that will be coming in later learning cohort webinars. We're trying to lay the groundwork here, and if we want to go with the hiking analogy, we're trying to build out the packing list. We figuring out what we need for the journey, the case, the skills, what kind of rain gear we need in case things get challenging. So we're working to get you prepared, working on the culture change of getting your leaders to buy into this so that they can see that connection between how addressing the housing needs of your community will improve health, equity, and value. And as Beth mentioned, we'd love to hear more about how you're making the case. We'll be joining you with that online platform, or you can email us to continue this conversation. So just really what's working, what are your challenges, and how are you making that value connection to resonate with your leaders. So next slide, please. We also have some resources if you want to do a deeper dive into any of these. So these are a list of resources from the American Hospital Association, as well as our partners at CCI. And on the next slide, we always have more resources to help guide your journey towards health equity and value and population health on the AHA website. So I welcome you to check out any of those and do a deeper dive into the work that we've been doing. And with that, I want to thank you all for listening and look forward to your questions after Ron's presentation.
Thank you very much. I appreciate Julia and Beth laying the groundwork on the health side, and I'm hopeful now that I'll be able to add the same from a housing side, keeping in mind that all housers are not equal, and definitely in my history of housing, I have more than 25 years of real estate development experience, and it started in a for-profit real estate space where we were always focused on how are we serving the needs of the folks who are going to either buy or rent the real estate that we had. And over the years, when I moved into public housing and eventually became the CEO of the Public Housing Authority in Rockford, Illinois, that same question came with me. However, what I found is systems in the public space didn't work that way. And oftentimes what we found were housers were of the opinion that folks were lucky to be getting affordable housing and they should be thankful for the roof that they were getting, which, to me was a very incorrect way to look at that if we were really going to help those we were working to serve. So I'm thankful now for all the experience that either I got as the CEO of the Housing Authority, I work with the Alliance for Strong Families and Communities, and now with Gorman and Company, because that's where all of these pieces get to come together for me. And I just want to focus on this slide for a second that we have to show that housing comes in all different forms and fashions. And at the end of the day, it must always look as though it's integrated into the community in which we're working to serve. And we should never look at an affordable housing development as a place where those folks live. And so we work very diligently to pay attention to detail and heritage and ultimately human dignity. And through that process, engage the community in housing solutions. So that's a lot about what we're going to talk about here is an engagement. So if you could go to the next slide, please. That engagement always comes because we're all married to a certain set of values and a core purpose. And I heard Julia and Beth both talk about mission, and obviously having worked in a for-profit space and nonprofit space and the government space, we talked about mission differently in each of those worlds. But at the end of the day, there was something that drove us all, and that mission drove us towards the vision. And what I find is we've worked across communities and we've looked deeply to work in community and help make that community ours. At the end of the day, the vision is often different, and that tends to be the impediment, that we come together with the vision of perhaps a healthy and equitable society, but all approaching what that looks like differently. And so here, I'm only sharing with you our core purpose and core values, because these have been with our company for the 35 years that we've been in existence, and they remain unchanged. And so as we work together, think about housing, food access, and ultimately the cohort with root cause over time, what are our common values that we're going to share, and how are we going to work to drive those? Because that will help you with your leadership on this work. It'll also help you at the community level as you work to build relationship and ultimately move to this intersection of health and housing and access. Next slide, please. So obviously we've already talked about the social determinants of health, and I think there's a number of ways to look at it. This is just a different graphic from the community health rankings model. I actually use this anytime we go into a new community to bring their county health rankings into the discussion with us. And folks often are a bit bewildered on why are we starting a housing conversation around health and the health outcomes or health factors of the county in which we're talking. And it's really to build the greater understanding that housing serves a greater purpose than just putting a roof over one's head. And the environment in which people live obviously has a great deal of effect on their health outcomes. And those factors in which they live in that neighborhood or that home can also drive those outcomes. And so getting everybody level set on that idea and really thinking that the housing discussion really needs to be focused and framed around policy programs and practices that drive those health factors and those health outcomes. And that stable, affordable housing is a foundation to that. Next slide, please. So there's a number of ways to look at this, and I put these few different slides in here so we could just maybe resonate with the various folks who are joining us today and who will join us as we go forward, because we all come from a different space. And so while we may have some child welfare folks who are on the line with us and really looking at foster care and kids aging out of foster systems, or we may have health service providers, or we may have FQHCs, we may have other housing providers. We all look at things differently, but they all in the end kind of say the same thing. And so while we're talking about ACEs and toxic stress, you can see those adverse community environmental issues below, which really align with the previous graphic and the graphic that Julia and Beth showed you on social determinants. So it's just different ways for us to look at it, but ultimately to align us around a similar conversation that may have different language, but focused on a vision where we're all trying to get to. Next slide, please. And this was one that we used at a model we used at the Alliance for Strong Families and Communities, and they had built a theory of change around systems change. And how were we going to drive an equitable and diverse society where folks felt included? And so that was core to everything we did. We looked at it from a social determinants lens, and you can see that around the outside, but ultimately coming to the recognition that if we were truly going to change systems, and in part that's what this conversation is about, how do we change the systems so that they're more integrated and less siloed? And we do that through both big P policy and little p policy. So big P is obviously the federal and the state, and the little p policy are those that you have within your organizations that drive towards hopefully the outcomes you're trying to achieve. And then the practice in which you do that, the regulatory environment in which you measure, and then ultimately the fiscal side of this, or the budgetary constraints that many of us all face. But at the end of the day, the only way we're ever going to bring these together is by having some sort of method of continuous improvement. As Julia and Beth spoke, particularly around their system redesign and improving outcomes, what I saw in that language and in that graphic they presented was a continuous feedback loop. How do we start with a vision of changing systems, and then at the end of the day, how do we measure that we've actually accomplished that through a series of steps, and then come back and have the conversation again to see if those outcomes are the ones we're trying to achieve. But all of us in this process, as I see it, become advocates for what is essential in public policy change, what is essential in organizational change, and what is essential for the engagement of folks at the community level through the highest offices of our organizations, as well as our government, to help bring people together to drive this change along a common understanding. Next slide, please. So at the end of the day, it's really all about people and having that shared vision and shared values. For a period of time, 3 years actually, I drove a planning, some called it a planning exercise. I called it an engaged planning effort with implementation built in, but it's called Choice Neighborhoods. Some of you may have heard it. It's a HUD program, Department of Housing and Urban Development, where HUD was saying we need to get beyond this idea of public housing folks being just housers, and the context or the neighborhood in which people live have an impact on their life, and there needs to be a holistic solution. So for 3 years, we sat with members of public housing who were living with us. We sat with the community who lived around them, the business leaders, the health leaders, the government leaders, and in over 100 meetings worked to come up with a vision for what this community wanted itself to look like. Not what we wanted it to look like, but what this community wanted itself to look like. And admittedly, at the community level, it was very difficult in the beginning to get folks to vision the future. And so for those of us who have, worked in the front line in communities and see the day-to-day toxic stress and trauma that exists in the neighborhood of high poverty, high crime, and violence, folks are trying to sort through the chaos to get through the day, and asking them to think about a future of what their family may look like in 5 years or 3 years or 6 months is difficult. But continuing to show up, continuing to be present, listening with the intent of hearing, and then ultimately seeking feedback from the individuals around the table, whether they were public housing residents or government officials, and then actually implementing that feedback and doing so through a continuous loop of improvement and reporting and communication was incredibly important. So the photos on the right side here, lower right, was focus groups we had with public housing residents. The ones above were community leaders. This photo on the left, though, is work I did when I was at the Alliance for Strong Families and Communities, where we went around the nation and worked with organizations who are really exploring where do they want to go and what does it look like. And this is a child welfare agency in just kind of middle America, if you will, in the East Coast, Presley Ridge. And Suzanne Cole was a wonderful partner in this. And so the reason I've got this, this really broad representation here is these are the folks that we're serving every single day as housers. This is the way I see it. This is the way we continue to focus in our work. And ultimately, you may not see health providers in this, but health providers are in this along every step of the way. And so really understanding what each of these folks want and need, and then helping them meet those needs and showing progress on those needs is important. So next slide. I share here through the planning work we did with Suzanne and her team, understanding what your CEO is trying to achieve and their role with their board and the direction the board has provided, the vision the organization has, and ultimately your mission. I mean, these are the things that CEOs and your leadership teams of organizations are really grappling with. And so you look at each of these, and is this what you would expect a child welfare organization to really be thinking about as they're conducting leadership, visioning, and strategic planning for the coming years? There is very little here that one would maybe say is connected directly to child welfare and foster care. But at the end of the day, these are the drivers of the organization, and this is what the leadership is thinking about. On the other end, of course, you have your clinicians and your programmatic folks who are really focused on serving the folks that are in their programs, helping them achieve success, whatever that success may look like, and then connecting them to the partners in the community who are really going to be able to assist in delivering that success. Next slide, please. So the other big piece is managing expectations, and I can share with you, and I didn't put this photo in here because I still find that hostile, but folks don't like folks who build housing, and there's a strong NIMBYism focus. And so for all of you in the health space, I really encourage you to think about how you may partner with housers to serve the greater need that we're all trying to accomplish. And so managing expectations across the continuum of folks in the community is very important. I think, up on the left here is typical public housing site that many of us may be familiar with, and yet on the right, this is a vision of what some folks think we're actually providing folks in the community. And the reality is those two photos on the left are often the case, what we're providing housing through. And that's not acceptable for me, and I think many of us as Americans. And so on the bottom right, it takes us back to that photo we started with in the beginning. And affordable housing must always come with dignity and express quality for the community in which you're living. Because at the end of the day, many of the social programs that are out there need to be better aligned, and housing, as I see it, is a platform in which to do that. But the way in which we treat people and the way in which we speak about them ultimately can become today or tomorrow's toxic stress. And so are we providing an environment development where folks can live healthy lives, and we can help them elevate the quality of that life. Next slide, please. So along the way, I always look at, I've always heard that you need to build buy-in. And I'd say buy-in is great, but buy-in isn't going to get the job done. What gets the job done is ownership. So we always start our work in housing and in community development discussions around housing with a checklist for the plan. How are we going to achieve the outcomes we all intend to achieve? And the first thing is really figure out what those are. What are the problems we're trying to solve for? And then what is the evidence-based practices or the evidence-based processes that work to get us there? We can create a vision from that. And as we do that, then we work to address the neighborhood problems, not from the context of a problem, but from the context of an opportunity. And then instead of just building buy-in and getting to that point of ownership, we want to all agree upon the responsibilities that we're taking on, the timeline for those responsibilities, and measurable outcomes. We've all moved as we've gone through the years, getting away from the number of people served or outputs to truly saying, are we making a difference? What difference did it make that we were involved in somebody's life? And is there a better outcome? Can we measure it? And then can we go back after that's been achieved and see if we can do it better next time with less friction and interruption? Next slide. So we often joke, Susan Dreyfus, who is CEO of the Alliance for Strong Families and Communities, talks about multiple goals, singular strategies. And so I was at a housing conference in San Antonio providing a presentation to a group of housers, and we were talking about health and housing. And at the end, a gentleman stood up and said, "Why are you asking me to do one more thing? I can barely get all that I need to get done in my housing world, and now you're asking me to help folks live healthier lives." And so, good question. At the end of the day, it's a honest question. But their mission and their vision was to not only provide affordable housing, but to provide families a pathway to self-sufficiency. And if folks aren't healthy, then they're not going to learn well, they're not going to work well, and they're not going to live their best life. And so in our planning in that Choice Neighborhoods effort with the Rockford Housing Authority, the housing on the lower left was an improved version of what it looked like originally. And we put in place interim steps to improve housing. Ultimately, housing on the right is now what it looks like. This was the first phase of completion. But through that, folks said, we want to be healthier. We want to live a better life, and we can't do it because we are unable to access healthy food. And so a grocery store was a conversation that kept coming up over and over again. And so we talked about providing a mobile grocery. And our residents said, if you do that, you will never come back to us with a real grocery store. So thank you, but we're going to push you harder. We want a real grocery store. And so ultimately, while this is a Save-A-Lot grocery store and not a Trader Joe's or not a Whole Foods, at the end of the process, what we found was most important for our residents, where they wanted access to not only healthy vegetables, but also good quality meats. And so in this particular case, we're able to leverage healthy food funds to create a grocery store that delivers locally grown and sourced foods, daily butchered meats on site, and ultimately met green environmental building codes that our residents came up with. And so while it's not entirely evident there's permeable pavers in the parking lot. They had their stormwater done on site. And the reason was that the neighborhood said we're tired of being impacted by poor quality development. So we want better quality development, even if we can't get that Whole Foods. And I have to say the Save-A-Lot's done a heck of a job. And I don't want to beat them up by any means, because they now are the highest grossing grocery store in their chain in Illinois. And they've hired all local residents from the neighborhood. So it started out as an effort around housing, provided access to healthy food, green building codes, jobs, and ultimately a new level of comfort, because this particular corner was also a very dangerous corner in years past, and now it's a place where people go to in a very positive way. Next slide. Also just want to touch base on a public housing property in Arizona called Madison Heights. It was a antiquated and struggling public housing authority, Maricopa County, and the housing authority there, new director came in, said, we need to make change. We want to focus this around health and education, and ultimately went through the whole community visioning process. And unlike many other communities, in this particular community, their school district said, we don't want you to go away, because this was located adjacent to a school property. And they said, if you go, we're going to have to close our school. What we would rather do is work together and figure out how to improve educational outcomes and living environments. And so through that, next slide, please, we're able to envision a new world and a new development. Next slide, please. And ultimately, this is what it looks like today. And so while this particular development does not have integrated health services like many of our others do, this one does have integrated human services. And so Maricopa County Human Services Department actually holds an office in this space and meets with our residents and our clients on a routine basis right there in the community center. And the reason we didn't bring health in is it's located near or adjacent to a clinic and a good health system. So there's no point in competing. Instead, there was absolutely every point in aligning and delivering services together. However, what we did agree on, next slide please, is really looking at how do we get folks to live healthier lives on site. And so gardening spaces, exercise paths, and a place where kids can play and just be kids and not worry about the struggles that life used to have in the former development. So we're very thankful to our folks at the Maricopa Housing Authority who really recognize this need to improve the quality of life of their residents through health and education. Next slide, please. The last piece, I started this discussion about talking about heritage and details, and they matter. The way we talk about folks, the way we work is either clinicians, practitioners, housers, health professionals, the way we face our folks as we come to serve them, and the value that you heard about earlier today is really driven when we pay attention and we focus on those details and we respect heritage. So in this particular example, we took what was very typical amenities in a public housing site, which was the former clothesline poles. We removed them, we worked with our kids and our families and artists and created this, what was an homage to their history, a piece of artwork that looks to their future and ultimately is driven by the folks who live there. And so, not health, but I would argue that art and health come aligned very well together. And then the last piece I'll leave you with is an effort where we did leverage arts with kids and families to bring folks together in routine creative spaces that ultimately had nothing to do with art, but helping people express themselves and build relationship. And then through that relationship, we turn that into an opportunity to address a health issue in a particular public housing authority property, which was smoking and mental health. And our HRSA data had showed that we had equal percentages of smokers and equal percentages of those with mental or behavioral health conditions that they self-identified. And using that data in this particular and other properties to go smoke-free, we're able to not just take a punitive approach of removing smoking from an environment and chastising folks in the process. Instead, we were able to use it to provide a wraparound service to address mental health because there is a correlation between the two. So before I jump to the side here and we talk questions, I just want to say it gets back to what you heard Beth and Julia talk about in understanding your data before you go in, looking for creative opportunities to connect folks, build relationship, share a common set of values and guide towards that vision. And at the end of the day, I think amazing things happen. I think that's where we're going to solve the intersectionality gap that currently exists between health, housing, and the social determinants.
Thank you so much, Ron. That was really, really fascinating. And Julia and Beth as well. I learned a lot. I hope everybody on the call did as well. We will now have at least a couple of minutes for Q&A. I don't see any questions posed yet in the question function of the webinar, so I will give that a few minutes to populate. And in the meantime, I think I'll ask you both a question. Clearly, the link between health and housing is so strong, and you guys have both done a lot to try to bring that link and make that case, bring the link closer together. If you could identify one intervention or change or resource that you would recommend that's been particularly impactful, what would you suggest? And this is for Ron or Julia.
Okay. As you say that, I think what I will say is a change is really looking at, I believe the gentleman's name is Richard Wilkinson, who's an economist. But in looking at the disparity of achieving health equity and economic mobility, he really speaks a lot in the way we talk about folks and the way we treat folks. And when we operate in silos, while we may not be saying anything, we're clearly sending a message that the work we are doing is most important, not the outcome that we are trying to achieve with you or that you are trying to achieve. Those are less important. And so I think the one change is really thinking through how we talk about the work we're trying to accomplish and treating people with respect and dignity in the process, whether it's health or housing or a continuum between.
Super, thanks. That's helpful.
Yeah, and I want to pick up on that silo thread. And I fully agree with Ron, your point. And we'll also add that I think in our worlds we get very focused on like what it is that we can do as our organization, or our sector, and lose sight of how many other people share those values and share those goals and want the same things for their communities. And just haven't figured out yet what it looks like to really work together in a collaborative way. So I would love to see a culture change around that, where we default to multi-sector work instead of having it be a bright spot exception.
Super, thank you so much. I see a couple of questions coming up in the question function. They're very small for me to see, so I'm going to try to make sense of them. I'll start with the first one. What additional organizations or hospitals are you partnering with to address housing? For example, is there precedent for working with educational institutions, universities, or land banks?
Can I go first?
Yes. Yeah. Yeah, I'd say all of the above. We're seeing hospitals increasingly partner with groups that I term unusual suspects. We have a population health survey that just came out today that I believe has some data on who hospitals are partnering with, and also the AHA measures this every year in our annual survey. But we are seeing hospitals partner with everyone from school districts to universities to payers to community development organizations to correctional facilities. Like there's no the scope of potential partners to work on housing is wide. And as I was saying before, I think that you'll find that when you drill down a lot of these organizations, while not explicitly part of their mission, their success depends on people having stable places to sleep at night. So there are many. I think if you start thinking about like what's everybody's value base and how drive the work that they want to do, you can connect around those shared goals.
I would say I'm seeing exactly the same, and I'll put some resources in the Formby site after today's webinar. But I won't focus deeply on exact examples, but I think we're seeing partnerships in not only just our properties, but across public housing organizations and other affordable housing providers. We're seeing partnerships with schools, with educational environments that are non-traditional, right? So not just public schools, but private schools, and looking at how education can continue once the school day ends and continues into a housing development, so that those kids who are struggling with educational attainment are actually getting the supports they need in their home environment. We're seeing, public health organizations working deeply in-home visitation. We're seeing healthcare providers provide clinics within affordable housing developments and hold hours at those clinics so that folks are able to be seen right there at or near home. And so there's a lot of those examples. As I said, I'll put them out there.
Thanks, Ron. I think we have time for one last quick one before we wrap up. I see a couple more questions that have come in, and we will post these questions on the Forum B site so that Ron, Julia, and Beth can weigh in with their perspective there as well. So let's end with the following. The question asks, who were your most unlikely stakeholders contributing to your housing effort?
Ron, I think that one's for you. Go ahead.
There were so many. I think I joked years ago when I was CEO of the Housing Authority and I went to a human services conference and I was a speaker, and I said, I think I looked around the room at many of you and you're probably looking at me and go, you're the problem we have, is the way you run these public housing sites. And you know what? It was true. And so what I found interesting was the service delivery that was intended in public housing was not necessarily what was being delivered because of interpretations of regulations. And so folks who seem to be very hardcore conservative on regulation and enforcement and punitive enforcement really come together to think about, well, that's not what we intended. And that's not the path we thought would be taken. And so having folks in positions of power sit with our public housing residents or those in need of affordable housing, in fact, homeless residents, hear it from a street end, because typically we were the translators and you wouldn't connect the two, the folks in the community who needed the help and the elected officials in the position of power to make the change. And so I would say they shouldn't be the ones who would be most unlikely, but they were the most unlikely that we were able to bring together. And that's ultimately what drove change.
Super. Thanks, Ron. I think we'll end it there. I just want to thank all of our speakers for today. This was terrific, and we look forward to continued engagement on the Forum B site. For everybody who's on as a participant, I encourage you to go onto the Forum B site. If you have any trouble whatsoever logging in, it's very straightforward to use. You can post documents, resources, comments, as well as see the dates for the January cohort. There will be no webinar in December, but we will have an active engagement on the Forum B site. And then the webinars will pick back up again in January. So let us know if you have any issues with that. You will see an email from Root Cause come through on Monday with a short survey to take about the webinar, as well as a question of the week that we'll pose to all of you to engage on via the Forum B site as well. So thank you today for your participation. And with that, I will turn it over to Monique to see if there's any last comments.
No, thank you so much for this wonderful session, and we look forward to seeing all of you participants engage through our forum platform. So thank you so much and have a wonderful rest of your day.
Thanks. Bye-bye.